Good morning, everyone. We'll be continuing our lectures every week, but this time I thought that I'll change things up a bit because I was busy with I was busy with a conference and some other work, so I was not able to prepare a good detailed lecture on the next lecture in dermatopathology. Because in lectures in dermatopathology, you require proper photographs, proper histopathological photographs, so that you can easily understand how to look at those structures. So I thought instead of skipping a week and preparing a lecture next week, I should cover a topic which is you could say a very uh, uncommon. Okay, it's a very rare disorder, and I should make a very small and short video on Dyskeratosis congenita. Now, there are certain disorders which you will not routinely see in your residency. I mean, in our residency and my institute used to get rarer cases. Even I saw even one or two cases of Dyskeratosis congenita, and that was it. And I thought that since these kind of disorders usually come as good quiz questions, or maybe in vivas it can be asked. So I thought I'd cover a very small video on Dyskeratosis congenita, and we understand intuitively how to how does this disorder present? Okay, what is the pathomechanism or what is the pathology behind DC? And slowly we'll understand what are the different clinical features in DC and what are the different differentials of Dyskeratosis congenita. So without much further ado, we'll start today's discussion on Dyskeratosis congenita. Okay, so let's start. Now, the definition of this, ever you get a short note on Dyskeratosis congenita, you start with the definition. Now, Dyskeratosis congenita is a heterogeneous group of inherited disorders of telomere maintenance. Okay, so what are the important words here? It is a heterogeneous group. That means this group contains different type of clinical manifestations, different types of disorders, but all of them have been clubbed together in an umbrella term of Dyskeratosis congenita. Okay, it's a heterogeneous group of inherited disorders of telomere maintenance. So that with definition we can know that the problem lies in the telomers. We'll discuss what are telomers. Don't worry. Other name is Zinsser-Engelmann-Cole syndrome, and this could be a good quiz question. Okay, Zinsser-Engelmann-Cole syndrome, and the inheritance is autosomal dominant, autosomal recessive, and X-linked, in which X-linked is the most common form of inheritance. Roughly about 50% of the cases are X-linked. There is a triad of Dyskeratosis congenita. Okay, this triad is nail dysplasia, oral leukoplakia, and reticulated hyperpigmentation, which can extend to be called as poikiloderma. Okay, so the triad includes nail dysplasia, oral leukoplakia, and reticulated hyperpigmentation or poikiloderma. Remember these 3 points, this triad. That this is important. It itself could be a good question in the viva. Now, additional features include bone marrow failure, pulmonary fibrosis, malignancy, and a lot of different organ systems are affected. Okay, and these are the extracutaneous manifestation of Dyskeratosis congenita, and these are the major complications and the reason for mortality in Dyskeratosis congenita. It's 1 in a million, and male gender is more affected by this. In fact, male to female ratio is roughly about 3:1. That means nearly about 3 times male involvement is there, and that we can easily understand because major cases are X-linked. Okay, and if male have XY chromosome, and if one of the allele is not working, this will lead to Dyskeratosis congenita. While females have two X copies, and if one of them is not working, the other might work. Okay, so you can get the normal phenotype because one allele is working. So females are less often affected, and they can be affected because of Lion hypothesis. Now, Lion hypothesis means that one of the X is mutated, and any other problem in the active or non-mutated X leads to a dysfunctioning gene. And this is the reason why many X-linked disorders can present in females because of inactivation of the normally working X copy. Okay. So we have already told you that 50% of the cases are X-linked. Females can have heterozygous mutations, and that is because of Lang hypothesis. There's a concept known as genetic anticipation. By genetic anticipation, we mean that if in a family people are getting affected by Dyskeratosis congenita, as the generation is increasing, more would be the clinical features and more severe would be the clinical features. This is known as genetic anticipation. Okay. So there can be earlier appearance of features or there will be increased penetrance. By increased penetrance, we mean that uh, more clinical features would be seen in subsequent generations, and this phenomena, the phenomena of genetic anticipation, is linked to autosomal dominant dyskeratosis congenita. Okay, we will understand why there's a concept of genetic anticipation in DC. Now, dyskeratosis congenita is a telomeropathy. Okay, so we have dyskeratosis congenita. Okay, dyskeratosis means that the keratinization is not going properly. That is why you have skin involvement, teeth involvement, nail involvement. Okay, and congenita because it is congenital. Now, telomeropathy means that there is a problem with the telomeres. Now, what exactly are telomeres? Let's imagine this to be a double-stranded DNA. Okay, and when a DNA is being replicated, let's say this is the replication fork. Okay, and in the replication fork, you have the replosome, which is just a collection of proteins which is responsible for replication of DNA. Okay, and it is creating another strand. Okay, this is just a schematic diagram. We will not go into details. That is beyond the scope of this lecture. Now, when this replosome is traveling along the DNA strand, it requires extra amount of DNA so that it can latch on to this extra amount and finish the duplication of the DNA. Okay, so that you can have some space for the entire proteins to move so that the DNA is entirely replicated. Okay, now this extra strand is are known as telomere. Okay, or is known as telomere. Okay, so the length of telomere decides how many times the DNA will get replicated, because with each replication, the amount of telomere is shortened. That means you have this amount, and when one replication happens, the telomere gets shortened. Another replication, the telomere gets shortened. So with every replication, the amount of telomere or the amount of nucleosides making the telomeres will get lesser and lesser, and the entire length of telomere will get shortened, shortened, shortened with each replication cycle. Okay. So if the telomere gets shortened to a certain extent, let's say only this much is left, the replicosome will not be able to attach itself completely, and the cell will not divide because DNA will not be replicated. So DNA replication stops. Okay. And the cell will undergo senescence or apoptosis because now it cannot divide. There's no point. Okay. In Dyskeratosis congenita, this telomere length is not maintained. So there is telomere shortening. So here you can see telomere shortening. Okay. So what all cells would be affected by telomere shortening? Those cells which are required to divide faster. So skin is affected, gut is affected, bone marrow is affected, liver is affected, lung is affected. All the areas where rapid replication is required. Okay. Now, dyskeratosis congenita is because of mutations in genes for telomere maintenance. So what exactly happens is that with every replication, some amount of telomere is also added so that it doesn't get shortened prematurely. And this action is because of telomerases. And this is responsible for the elongation of telomere so that the cell can easily replicate in subsequent cycles. But if there is a problem in either telomere or telomerase or the replication mechanism of the lengthening of telomere, it will lead to dyskeratosis congenita. And different types, or you could say multiple types of proteins are required for this replication of telomeres. And if there's a mutation in any of them, you will have dyskeratosis congenita. If that mutation is X-linked, autosomal dominant, autosomal recessive, will lead to the specific type of dyskeratosis congenita. Okay. Multiple genes have been identified, but roughly about 12 genes account for 70% of cases. The shortened telomeres arrest the cell cycle, they arrest the cell proliferation, and the cell goes into old age or apoptosis. Because of this telomerase dysfunction, the chromosome is now unstable. Why unstable? Because let's say one chromosome has that deficiency and is not able to divide properly. The whole cycle is the whole cell cycle is arrested. The cell is not able to properly multiply or replicate. This leads to multiple mutations leading to tumorigenesis or tumor formation, and this is the reason why you have a lot of malignancies in Dyskeratosis congenita. Okay, let's move forward. The most common gene linked is Dyskerin, or the most common protein linked with Dyskeratosis congenita is Dyskerin, and it is encoded by DKC1 gene. And this leads to X-linked DKC. Now, this could be a good quiz question. The other proteins, remember I told you that many different kinds of proteins are required for the telomerase action and telomere lengthening. Some of the proteins are telomerase reverse transcriptase, telomerase RNA component, which acts as a template for telomere formation, and shelterin, which regulates telomere length by acting as a cap at the telomere. Okay, so these are the multiple genes which are required for maintaining telomere length. If there's mutation in any one of those genes, you will have Dyskeratosis congenita. Okay. So as we have said that X-linked accounts for about 50% of the cases, roughly 10% of the cases is there's mutation in TINF2. Now TINF2 is one of those proteins required for proper length of telomeres. There are other proteins like NHP2, NOP10, GAR1. These act as stabilizers. Now what essentially is happening is a group of molecules are coming and they are maintaining the telomere length. In order for the group of molecules, group of proteins to act properly, you require stabilizers that will stabilize the structures. And NHP2, NOP10, GAR1 act as stabilizers. Okay. So any of these proteins, any of all of these proteins that we have mentioned, if there is a mutation, you will have this keratosis congenita. Okay. But remember the most common protein is Dyskerin. Let's move forward. Now this diagram I've taken from Bolognia 5th edition, page 1145. And this actually shows you different proteins involved, RTL1, TAN, TNF2, which leads to 10% of the cases, TERF, shelterin, TERT. Here is the Dyskerin, which leads to X-linked DKC. Okay. Now this whole is the protein complex required for proper telomere length. And here you can have the telomerase enzyme, which is responsible for elongating telomere with every cell cycle. Okay. So here you can see that these extra strand of DNA is telomere. And with every cycle, every replication, you can see these are successive telomere shortening with each cell division. Every time the cell divides, telomere gets shortened. And after a certain critical length, the telomere is not able to elongate properly and the cell will undergo senescence or apoptosis. So if we go forward, the clinical features include a variable phenotype, even if mutation is the same. So even with same mutation, you can have different clinical features. Okay. The complete triad of nail involvement, skin, and the involvement of oral leukoplakia is seen in about 37% of the cases, while the complete absence of triads occur in the autosomal dominant Dyskeratosis congenita, and roughly about 10% of the cases do not have the do not have the features of the triad of DKC. Now, two-thirds of the triad or one-third of the triad or plus more than one recognized features, you should actively consider DKC. Okay. As we have said that the entire triad is present in 37% of cases, you might not have the entire triad at your disposal. But if you have two-thirds of the triad available or one-third of the triad available, plus few recognized features, you consider DKC. Okay. But remember, more the features, the more would be the complications like bone marrow failure, mortality, etc. Okay, let's move forward. Now, these are the additional features. The major features are present in more than 75% of the patients, like nail dystrophy, leukoplakia, abnormal skin pigmentation, bone marrow failure. By abnormal skin pigmentation, we mean poikiloderma. Okay. Now, other recognized features are about 10 to 75% of the patients, in which you have short stature, sparse hair or premature graying, hyperhidrosis, epiphora because of lacrimal duct atresia, blepharitis, abnormal eyelashes, developmental delay, pulmonary issues, strictures, tooth decay, SCCs. Okay, these are all features, these are all the additional features that we were talking about. Let's move forward. Now, nails show dystrophy, okay, and they start by the age of 5 to 13 years, the nails start undergoing dystrophy. There is more ridging and longitudinal grooving, okay. The nails are shortened and there is pterygium formation, so much so that complete destruction of nail occurs. Complete destruction of nail occurs. The nail can entirely be absent. In skin, the skin gets started to involve from late childhood to teenage years. It presents with a fine reticulate dusky brown hyperpigmentation which eventually forms poikiloderma, and this is the most characteristic cutaneous feature of DKC. So here you can see in this diagram that this mottled kind of fine reticulate dusky brownish color hyperpigmentation is seen in the starting stages in DKC, which eventually leads to poikiloderma. Okay. Now, this hyperpigmentation may not be that apparent in dark-skinned individuals like of the Indian descent, but in Caucasians you can easily appreciate. While people of Indian descent, when they come, they usually have the proper development of poikiloderma on the skin. These are additional features. You can see this speckled pigmentation, and see for poikiloderma to happen, you need to have telangiectasias and atrophy. So that eventually starts to develop. We can have oral leukoplakia. You can see thickening of the tongue with whitish lesions here. I have a better picture on the next slide. We can see the pterygium formation, or actually the complete nail dystrophy can be seen here. The nail is dystrophic. There is thickening of the palmar skin, so much so that palmar hyperkeratosis can happen, and even in the soles you can have hyperkeratosis. So palmoplantar hyperkeratosis is also linked in DKC. So DKC is a disorder of poikiloderma. It is also a disorder of palmoplantar hyperkeratosis. Now, telangiectasia usually develops on the trunk. The face will have a redness or atrophy starts to develop with the advancing age. You can have acrocyanosis, that means cyanosis of the tips. The hair is sparse, lusterless. You can even have early whitening of hair. Hands and feet can show palmoplantar hyperkeratosis. There's hyperhidrosis, so much so that bulla might form on palms and soles. Okay, so this can be increased sweating over the palms, leading to bulla formation. The dorsum of the hand might have atrophic lesions which are transparent and shiny in appearance. Now, what exactly is happening is this, that the skin is not able to divide properly because of altered telomere length. And that is why the layers of skin are not properly formed and you have atrophic lesions. You have telangiectasias which are reactionary to the entire disease process. Okay, and since the skin layers are not properly formed at the areas of thickened skin, you have hyperkeratosis. So palmoplantar hyperkeratosis is seen. Let's move forward. In the mucosa, the most common mucosal change is leukoplakia. And this leukoplakia has about 1,000 times the increased risk of developing SCC. And this could be a good quiz question. Okay, 1,000 times increase of SCC. Other features include peritonitis, blisters, erosions in the oral or anal mucosa, esophagus, urethral strictures can also develop. Okay, the teeth is defective and leads to early decay. So what exactly happens is there's enamel destruction. We all know that with constant wear and tear and constant chewing, the enamel undergoes destruction. Okay, and because we don't have good amount of telomeres, the cells are not dividing properly, and that is why the teeth becomes become defective and they decay quite early. In the eyes, you will see tarsal conjunctiva inflammation, which can lead to lacrimal duct atresia, leading to excessive lacrimation. So the lacrimal duct is blocked and leading to excessive lacrimation. Chronic inflammation of eyelids, conjunctivitis, ectropion are also included. This you can see in eye. Okay, so these are the mucosal manifestation of DKC. So let's see again the leukoplakia. So here you can see a leukoplakia. Let me change the color. So in this photograph, you can easily appreciate leukoplakia. You can see this kind of, can you see telangiectasias here, here, here? So these are all telangiectasias along with pigmentation. Atrophy is not much appreciable, but it shows a picture of poikiloderma. We can see that the nails are completely gone. Okay, there is significant nail dystrophy. There's anonychia happening now. That is complete absence of nails. You can look at this. I've given the references for textbooks. You can open the textbook and go through these pictures. Similar similar features are being shown here. I've taken this from an article. This is the article. I'll mention this article in the description so that you can copy paste and go. And there are the different stages of, see here you can have a pterygium formation, nail dystrophy, destruction of the entire nail plate, okay, and the thickening of the palmar skin, leukoplakia. So you can go and read this article. This article has a lot of good pictures showing the clinical manifestations in DKC. So in histopathology, we usually don't biopsy any, we don't need to biopsy lesion of DKC. The diagnosis is made clinically and it is confirmed by genetic analysis. Okay. If you can find the specific mutation of DKC, you can easily understand that this is the process going on. So what are there only subtle non-specific features seen on histopathology? So we usually see hyperkeratosis, that is thickening of the epidermis. Let me change the color. Yeah, thickening of the epidermis. There can be epidermal atrophy. So here you can see that the epidermis is here thinning out. So what exactly is hyperkeratosis is that there's increased corneum layer. I think I misspoke and I'll explain it again. In hyperkeratosis, there's thickening of the corneal layer. So the corneal layer is thickened, but the entire thickness of the epidermis is less. So the entire epidermis is less, but the majority of that epidermis is formed by the corneal layer. So hyperkeratosis is seen along with epidermal atrophy. Why atrophy? Because the cells are not able to divide properly. There are telangiectasias, that is dilated vessels. So this is a dilated vessel here. Okay, so this leads to clinically telangiectasias. There is dilatation of epidermal vessels. There's mild lichenoid infiltrate. In fact, in this picture, you are not able to see much of lichenoid infiltrate, but that can be there. There can be features of lichenoid dermatitis on histopathology and melanophages because we see poikiloderma and these are the features of poikiloderma essentially. So these all features are actually histopathology features of poikiloderma. Okay, so these are the cutaneous features that we have seen in the previous slides. Now we'll head on to some complications which are mostly asked in your vivas and quizzes. Life-threatening bone marrow failure is seen in about 50 to 90% of the cases. Okay, so this is the major cause of mortality. So major cause of mortality is actually bone marrow failure. Bone marrow failure. Now, it presents with severe aplastic anemia with neutropenia, splenomegaly, hemorrhagic diathesis. These are all complications that happen because of bone marrow involvement. Now, i- let's say that bone marrow failure is seen in about 50 to 90% of the cases, but bone marrow is affected to a larger extent in DKC because the cells, again, these are the highly proliferative cells which are not able to divide because of telomeropathy. Cytopenias are the first sign, which is self-explanatory. If bone marrow is involved, the cell counts will go down. Okay, X-linked DKC. autosomal recessive, like all recessive disorders, and DINF mutations. Remember, this is the same mutation which causes roughly about 10% of the cases. They have severe manifestations. The clinical involvement is much more severe as compared to the other different types of mutations that we usually see. Patients with dyskeratosis congenita have about 73 times the increased risk of acute myeloid leukemia and about 500 times the risk of developing myelodysplastic syndrome. So these are all data which I've taken from the Rooks latest edition, 10th edition. So if any kind of MCQs, this could be easily asked that you can have 5,000 times the risk of myelodysplastic syndrome, about 1,000 times the risk of leukoplakia developing into SCC, and 73 times the risk of acute myeloid leukemia. Other complications include pulmonary fibrosis and hepatic cirrhosis. These are all the organs which are undergoing repeated damage and they require repeated cell replication to make sure that the organ is okay. But because of improper cell division, they're not able to maintain that homeostasis. The epithelial tumors are seen mid-teens and onwards, and mostly the mucosa is affected first. Remember, you have leukoplakia as a manifestation. It's part of the triad. Most commonly, you will see tongue involvement. We have already seen the clinical photographs in previous slides, in which most of the photographs showed involvement of the tongue. And tongue SCC becomes the most common carcinoma associated. Okay, so most common risk of mortality is bone marrow failure. Most common carcinoma is tongue SCC. The life expectancy in DKC is about 44 years roughly, as per at least Rook's 10th edition is concerned. Now, differential diagnosis of DKC essentially involves a list which has congenital poikiloderma. Okay, so congenital poikilodermatous disorders. Now, what are these? What are these disorders? You have Rothman-Thompson syndrome. You have EB simplex with motile pigmentation, Naegeli-Francesche's Richardson syndrome, dermatopathia pigmentosa reticularis, and Claricuzio type poikiloderma. So these are all 5 disorders mentioned in Brooks, but important disorders to remember are Rothman-Thompson, you have NFJ syndrome, and DPR. Okay. A good thing about DPR is that it has the features of DKC, but it does not have leukoplakia or bone marrow failure because the mutation is there in keratin 14. Okay, it is skin limited. So mucosal involvement like leukoplakia and bone marrow involvement like bone marrow failure is not seen, but otherwise other cutaneous features of DKC is seen in DPR. The nail changes are nearly can be confused easily with nail lichen planus or GVHD, but remember you have to take all the different clinical features together. Investigations essentially are just to look for different complications, for example, CBC, LFT, KFTs, and abdominal ultrasound to look at liver involvement, PFTs to look at lung involvement. If you really want to diagnose this, the diagnostic test is flow cytometry and fluorescence in situ hybridization, which is flow fish of leukocytes. And in those leukocytes, you look at the telomere length. If the telomere length is shortened, this is seen in DKC. So that is how you diagnose. You do flow fish of leukocytes and you see the telomere length. If that is shortened, that is what we see in DKC. Now remember, the study of Dyskeratosis congenita actually led to the discovery of connection between telomeres and cell aging. So that is how important this disorder is. Further, you can do genetic testing panel for bone marrow failure disorders. Multiple congenital disorders have mutations in different genes that leads to bone marrow failure, and you can test for the panel. And if you have mutations in, let's say, TINF or TERT or TERK, so you can easily diagnose the lesser common DKC disorders. A patient of DKC has to undergo annual screening with CBC, PFT, gynecological examinations for mucosa involvement, cancer screening, which has to be done annually by dermatology and ENT specialists so that you can early detect cancer and take care of them. Biannually, it is recommended that a dentist should examine a patient for oral carcinomas because remember, oral carcinomas are a feature of DKC and they have very high potential of developing into frank SCCs. Okay, let's move forward. Now, management of congenital disorders are actually very simple. Essentially, they are not there. the way to manage congenital disorders are to manage complications. So bone marrow failure. How do we describe bone marrow failure in DKC? It is persistent decreased hemoglobin less than 8, persistent decreased platelets less than 30,000, okay, decreased neutrophils less than 1,000. So if any of these characteristics are present in a patient of DKC, the patient is in bone marrow failure and you should consider bone marrow transplant. Hematopoietic and immunological defects can only be treated by allogenic stem cell transplantation. And stem cell transplantation is the current available technique just to take care of any complication that might arise from DKC. Not highly successful. The survival rate ranges from about 63 to 65%. You have lifelong antibiotics and immunosuppressants. These are there. The normal risk associated with bone marrow transplant are there again with DKC. Okay. Other drugs like androgens, which includes oxymetholone and danazol, they have been shown to improve blood counts. So if you have to mention oral drugs, these are drugs that you need to mention, androgens. For mucosal plaques, you do curettage or you surgically excise, but the lifelong screening continues. Let's say you have a patient of DKC and the patient has oral leukoplakia and you end up removing the entire leukoplakia. You still have to screen because new development can always happen. Other drugs like erythropoietin to increase hemoglobin levels, GM-CSF to increase leukocytes, L-Trombopac increases platelets, and romiplastrum also increases platelets. These can be given to the patient so that the counts will increase. Remember, cytopenia is the first sign of bone marrow failure, so you can give these drugs to increase the individual cell counts. Okay, so with that, we'll finish this week's discussion on Dyskeratosis congenita. These are the individual chapters in Rooks, Bolognia, and Fitz. These two articles are good if you want to read more about Dyskeratosis congenita, but this lecture is all you require, including any clinical features and manifestations. And DKC is a good spotter, it's a good quiz question. So if you can go through rapidly through this lecture, you can easily understand what is the reason of DKC. We have telomerase problems, we have shortened telomeres, and because of that, the rapidly dividing cells are not able to properly replicate, and you have issues in skin, which includes oral leukoplakia, you have poikiloderma over the trunk, and you have nail dystrophy. So this is the involvement for the dermatology side. The major complications are bone marrow failure, seen in 50 to 90%, which is the major risk of mortality, along with other complications like hepatic cirrhosis, pulmonary fibrosis, eye involvement in the form of tarsal inflammation, lacrimal duct atresia leading to epiphora and lacrimation. So all of these disorders can happen, but if you know what is the underlying pathology, you can easily remember all of these disorders. So with that, I'll finish this week's lecture and it will not take much of your time. This is a shortened lectures compared to others. Next week, if I do get time, we'll switch back again to dermatopathology and finish the reaction patterns. With that, I'll finish. Any doubts, suggestions, or queries can easily be written as a comment below the video and I'll answer them. Otherwise, nothing else has to be done. We'll finish. Adios and bye.